My name is Binga-an, a fourth-year nursing student from Negros Oriental State University here in Binga-an. And as part of our online requirement for Nursing Care Management 106, I am going to discuss with you about nasogastric tube feeding.
Nasogastric tube feeding. Nasogastric tube feeding involves the delivery of nutrients directly into the stomach via tube. It is used to either supplement or replace oral nutrition as long as the GI tract is physically capable of receiving and absorbing nutrients. It is the preferred method for providing nutrition support whenever possible. It is safe and usually more cost-effective than parenteral nutrition and is also significantly less likely to cause sepsis and other serious complications. The type and frequency of feedings and amounts to be administered are ordered by the physician. Liquid feeding mixtures are available commercially or may be prepared by the dietary department in accordance with the physician's orders. Its purpose is to provide enough support for body requirements, to restore or maintain nutritional status, and to minimize complications. Feedings can be given continuously or intermittently. For continuous feeding, it is similar to IV therapy in that small amounts are continuously infused by gravity drip or by pump or a controller device over a specified time. Intermittent or bolus feeding, when longer-term support is needed, an intermittent schedule with delivery of the feeding to the stomach best replicates a normal eating pattern. This method can be accomplished manually or by infusion through a mechanical pump or controller device. It also permits the patient to be free of the tube feeding for long periods of day, and feedings are administered typically 4 to 6 times per day. Procedure. First, for the equipments, we need a measuring container for which to pour the feeding, water, 50 to 100 ml as ordered at room temperature, a septal syringe, correct feeding solution, and stethoscope. For the assessment, auscultate for bowel sounds before each feeding or every 4 to 8 hours for continuous feedings. Also check for distension, nausea, vomiting, and diarrhea. Assess frequency of bowel movement, and check patient history for food allergies. Implementation. Check the doctor's order. Take note of the ordered amount per feeding. Perform hand hygiene. Prepare the authorized feedings as ordered. Transfer ordered amount of feeding in a small bottle. Allow the formula to reach room temperature before using and refrigerate the remaining formula. Explain the procedure to the client. Provide privacy and check the position of the client. The position of the client with the tube feeding should always remain with the head of the bed elevated at least 30 to 40 degrees. Do not place the client in a supine position. This may lead to aspiration pneumonia and death from pulmonary complications. And then attach a septal syringe to end feeding tube. Check the tube for correct placement by at least 2 and preferably 3 of the following methods. Aspirate stomach contents, check pH aspirate, introducing air, and confirm by X-ray. Aspirate stomach contents. Stomach aspirate will appear cloudy, green, tan off, white, bloody, or brown. It is not always visually possible to distinguish between stomach and respiratory aspirates. Note that the small diameters of the NG tubes make aspiration problematic. The tubes themselves collapse when suction is applied via the syringe. Thus, contents cannot be aspirated. Check pH aspirate. Measuring the pH of stomach aspirate is considered more accurate than visual inspection. Stomach aspirate generally has a pH range of 0 to 4, commonly less than 4. The aspirate of respiratory contents is generally more alkaline, with a pH of 7 or more. Introducing air. Inject 30 ml of air into the stomach and listen with a stethoscope for the whoosh sound of air into the stomach. Note the small diameter of some NG tubes may make it difficult to hear air entering the stomach. Last is confirming by X-ray. X-ray visualization is the only method that is considered positive. Next is to kink the nasogastric tube. Then remove the valve of the aseptic syringe. Pour feeding into the syringe and unkink the NGT. Raise the syringe to 12 to 18 inches above the stomach. Allow feeding solution to flow slowly into the stomach. Raise and lower the syringe to control the rate of the flow, and then kink the NGT and add additional formula to the syringe as it empties until feeding is complete. Note, pinch or clamp the tubing to stop the flow for a minute if the client experiences discomfort. Instill 50 to 100 ml as ordered of water through the feeding tube or medication port. Be sure to add water before the feeding solution has drained from the neck of the syringe or from the tubing of an administration set. Clamp the feeding tube before all the water is instilled, and ask the client to remain sitting upright in Fowler's position or in a slightly elevated right lateral position for at least 30 minutes, and then wash the aseptic syringe. Wash it thoroughly with soap and water so that it is ready for reuse. Document the feeding, including amount and kinds of fluids administered. Feeding plus any water used to flush the tubing. Duration of the feeding and assessment of the client. Record the volume of the feeding and water administered on the client's intake. What type of formula to give? When GI tract is fully functional, we have polymeric or standard, high nitrogen, and concentrated. Polymeric contains whole proteins, 10% to 15% of calories, long-chain triglycerides, 25% to 40% of calories, and glucose polymers or oligosaccharides, 50% to 60% of calories. Most provide 1 calorie per ml. It is indicated for patients with inability to ingest food and inability to consume enough to meet needs. Clinical examples: we have oral or esophageal cancer, stroke, anorexia resulting from chronic illness, burns, or trauma. Examples of these commercial products: we have Ensure, No Basics, Isosaurus, Pediasure for children's 1 to 10 years old, and Boost. For high nitrogen, it is the same as polymeric except that protein provides greater than 15% of calories. It is indicated for patients with inability to ingest food, inability to consume enough to meet needs, mild catabolism, and protein deficits. Clinical examples: we have burns or trauma and sepsis. Examples of commercial products are Isosaurus HN, Osmolite HN, and Ultracal. Concentrated. It is the same as polymeric except concentrated to 2 calories per ml. It is indicated for patients with same as polymeric but fluid restriction is needed. Clinical examples, we have heart failure, neurosurgery, COPD, and liver disease. Examples of commercial products, we have Deliver 2.0, 2-cal-HM, and Nutrin. When GI function is impaired, we have elemental or predigested. It contains hydrolyzed or partially digested protein, peptides or short chains of amino acids and or amino acids, little fat, less than 10% of calories, or high MCT, and glucose polymers or oligosaccharides. Most provide 1 calorie per ml. It is indicated for patients with impaired digestion and or absorption. Clinical examples, we have short bowel syndrome, radiation enteritis, and inflammatory bowel disease. Examples of commercial products, we have Critical Care HN, or Criticare HN, Vital High Nitrogen, and Reabulan HN. There are diets for specific disease states. These diseases include renal failure, hepatic failure, pulmonary dysfunction, glucose intolerance, critical care, and wound healing. For renal failure, these diets are concentrated in calories, low sodium, potassium, magnesium, phosphorus, and vitamins A and D, low protein for renal insufficiency, higher protein formulas for dialyzed patients. It is indicated for patients with renal insufficiency and dialysis. Clinical examples, pre-dialysis, hemodialysis, or peritoneal dialysis, and examples of commercial products are Soplina, Renalcal, Nepro, Magnacal, Renal. For hepatic failure, the diets are enriched in BCAA and low sodium. It is indicated for patients with protein intolerance, and the clinical examples are hepatic encephalopathy. Examples of these commercial products, we have NutriHep and Hepatic Aid 2. For pulmonary dysfunction, the diets are low carbohydrate, high fat, concentrated in calories. It is indicated for patients with respiratory insufficiency. And for clinical examples, we have ventilator dependence. For examples of these commercial products, we have Nutrivent and Pulmocare. Next is glucose intolerance. Diets have high fat, low carbohydrate, and most contain fiber and fructose. It is indicated for patients with glucose intolerance, of course, and the clinical examples are individuals with diabetes mellitus whose blood sugar is poorly controlled with standard formulas. Examples of commercial products are Glucerna, Choice DM, Diabetisource, and Glytrol. And last is critical care or wound healing. Diets have high protein, most contain MCT to improve fat absorption, some have increased zinc and vitamin C for wound healing. Some are high in antioxidants such as vitamin A and beta-carotene. Some are enriched with arginine, glutamine, and or omega-3 fatty acids. It is indicated for patients with critical illness. In the clinical examples, we have severe trauma or burn sepsis. Examples of these products are Immune Aid, Impact, Parative, Crucial, and Traumacal. Managing complications. For complications, they are divided into 3: gastrointestinal, mechanical, and metabolic. For gastrointestinal, we have diarrhea, nausea, vomiting, gas bloating or cramping, and constipation. Diarrhea, its causes are hyperosmolar feedings, rapid infusion or bolus feeding levels, cold formula, medications, especially antibiotic therapy. For selected nursing intervention, assess fluid balance and electrolyte levels and report findings. Implement changes in tube feeding formula or rate. Review medications, appropriate rate of infusion and temperature formula, and avoid multiple elixirs and pro-motility medications. Next is nausea or vomiting. Its causes: change in formula or rate, inadequate gastric emptying. Selected nursing intervention. Review medications, check residuals if 200 ml, reinstall and recheck. Report if residual is consistently high. Next is gas bloating or cramping. Its causes are air in tube and excess fiber. Selected nursing intervention, we have to notify the physician if persistent and keep tubing free of air. Constipation. The causes are lack of fiber, inadequate fluid intake or dehydration, and opioid use. For selective nursing intervention, check fiber and water content, report findings, administer adequate amount of hydration as flushes, and consider cathartic. For mechanical, we have aspiration pneumonia, tube displacement, tube obstruction, and nasopharyngeal irritation. Aspiration pneumonia. Its causes are improper tube placement, vomiting with aspiration of tube feeding, and flat in bed. Selected nursing intervention, we have to assess respiratory status and notify physician. Implement reliable method for checking tube placement and keep head of bed elevated at least 30 degrees. Tube displacement. Its causes: excessive coughing or vomitus, tension in the tube or unsecured tube, tracheal suctioning, and airway intubation. Stop feeding and notify physician. Check tube placement before administering feeding. Next is tube obstruction. Its causes are inadequate flushing or formula rate, inadequate crushing of medications, and flushing after administration. Nursing intervention, we have to follow policy for declogging feeding tubes, obtain liquid medications when possible, and flush tube and crush medications adequately. For nasopharyngeal irritation, its causes are tube position or improper taping, and the use of large tubes. Nursing intervention, we have to assess nasopharyngeal mucous membranes every 8 hours. Tape tube to prevent pressure on nares, and reposition tape. Last is metabolic. For metabolic, we have hyperglycemia and dehydration and azotemia or excessive urea in blood. Its causes: glucose intolerance, high carbohydrate content of the feeding. Nursing intervention for hyperglycemia. We have to check blood glucose levels routinely. Dietary consult to re-evaluate feeding regimen. For dehydration and azotemia, its causes are hyperosmolar feedings with insufficient fluid intake. Selected nursing interventions are to report signs and symptoms of dehydration, provide adequate hydration through flushes, and implement changes in tube feeding, formula rate, or ratio to water. For more inquiries, Please contact my email address kiara91.omali@gmail.com, or you may contact my number.
A nasogastric feeding tube is a special tube inserted through the nose for delivering oral nutrition supplements and medication into the stomach. You are required to feed the patient based on the feeding schedule. Please take note of the time, type of oral nutrition supplement, and amount needed. You will need to prepare the following: oral nutrition supplement as prescribed, 50 ml syringe, a jug of water, pH strips and a small bowl, small cups, measuring tape, medication if any, and the feeding schedule. The feeding schedule will be given to you upon discharge. Step 1. Wash your hands with soap and water. Step 2. Prop the patient up to at least 30 degrees. Step 3. Ask the patient to open his mouth and check the back of the throat. This is to make sure that the tube is not coiled. Ensure the recommended external length of the feeding tube is measured and consistent during each feed. The feeding tube should be secured firmly to the nose and cheek with a tape. To check if the feeding tube is in the stomach, withdraw some gastric content with the syringe. If you're unable to obtain gastric content, lie the patient on their left side. Inject 10 to 20 ml of air into the tube and make another attempt to withdraw gastric content. If you're still unable to obtain gastric content, please wait for 15 to 30 minutes and try again. Read gastric content pH level. If the pH level is below or equal to 5, he is ready to be fed. Please note that pH levels can be affected by certain medication such as proton pump inhibitors, H2 antagonists, or antacids. If the patient is on other medication, please check with your doctor or pharmacist, as they might also influence the pH results. Step 4. Feeding of oral nutrition supplement. Check the feeding schedule. Prepare the correct amount and oral nutrition supplement prescribed. Prevent air entry into the stomach by kinking the feeding tube before connecting the syringe. Flush the tube with 20 ml of water or as per prescribed. Feed according to the feeding schedule. Position syringe slightly above the head. Ensure the syringe is not empty during feeding. This is to minimize stomach discomfort due to excessive air entry. Complete the feeding by flushing 20 ml of water or as per prescribed and close the feeding port with a stopper.
My darling, I love you, I love you, I love you, I love you.